We're going to go ahead and get started with the FES panel, a postgraduate course. Welcome all of you that are here early this morning. Just a couple housekeeping things I want to mention as we get started. Each of the presenters will show a disclosure slide as part of their presentation, but I want you to know that all the presentations have been screened and any potential conflicts of interest addressed ahead of time, so that has been addressed. The second thing is we're using for the first time here at this meeting a new audience dialogue and response system, and you will see flashed on the screen periodically through the morning ways that via Twitter or email or SMS you in the audience can give questions or feedback with regard to the presentations, and we will try to factor those things into the panel discussion at the end. Finally, just remember for CME purposes, you should have a form that you can complete with regard to this session. We greatly value that feedback. I want to start just by introducing our first speaker, Sam Finlayson. Sam comes from Dartmouth, and he has done a lot of work over many years, and I've learned a lot reading his papers over the years with regard to the rural surgery workforce and the importance of endoscopy as part of the provision of care that's rendered through that group of people. So we'll welcome Sam to kick this off.
I was asked to give this talk. I'm now at the Brigham and Women's Hospital, where I'm director of the Center for Surgery and Public Health. That isn't it. And nothing to disclose. Great. So this is what I'm going to talk about today. I'm going to talk, first of all, a little bit about surgical workforce concerns, because that's been very prominent in policy discourse. We'll talk then about surgeon supply trends, and there's some controversy around this, which I will explain. Then we'll talk some about surgeon distribution, both geographically, rural versus urban areas, and then some of the effects of specialization on the data. And then finally, we'll close with talking about general surgery and endoscopy, specifically talking about rural practice and how practice location bears on the endoscopy, or the role of endoscopy in practice, and then finish up with some implications and conclusions. So you've probably seen in the journals quite a bit of concern about general surgery workforce, and the two areas that seem to get the most attention. One are urban trauma surgeons. As an example is the very cleverly worded title of this Hiram Polk paper, a very busy urban surgeon, another face of the ever more obvious shortage of general surgeons. I personally took that as a little bit of an affront, because I've always been saying that we don't have a shortage of general surgeons. I thought maybe he was talking to me. Then also rural surgeons. Seems to be there's not quite enough, and this has been borne out specifically with surveys of hospital administrators showing a very high percentage of them actively looking for a surgeon to staff their hospitals, and also reporting very long periods of time required to recruit them when they do have them. Also a lot of unfilled fellowships. Another big impact on not just surgery but physician workforce in general was the balanced budget amendment, which is now about 10 years ago, that limited the number of graduate medical education slots, or the number that would be subsidized by Medicare payments, and it's really limited the growth in residency education. And then finally, there's been a lot of actual research, in addition to the anecdotes about not having enough surgeons around, that is showing a diminished growth in physician workforce, and particularly some work done by Buzz Cooper, and then some good work coming out of Washington. Dana Lynch, who's shown that there's quite a bit of variation in number of surgeons geographically. This is from Buzz Cooper's data on total physician supply. You can see that there's a pretty straight line up until the mid 2000s when and these are projected numbers, where the supply starts to flatten out. He calls that middle line supply, and then effective supply he draws in a lower line because, as he would explain, there are more surgeons who are not working the same number of hours as worked before. And then the line that continues is what he proposes is the demand. And that other line that also goes up along with demand is the supply if Congress had allowed GME spots to continue to grow. There is some caveat here that when you look at this data, you have to be careful about the details. And one of those details is, you'll notice that on the y-axis is physicians per 100,000 of population. So it's not saying the total number of physicians, it's saying the total number per capita, which makes you wonder, why is it that we didn't need those many surgeons before, and why is it that we're projecting to need more and more? And if you, as an exercise, continue the line, eventually you get to the point where there's one physician per person, which doesn't make a whole lot of sense. So at some point the line should flatten out when we've reached the number of physicians that we need to meet our health needs. But I think that there is legitimate concern that that curve seemed to be bending for social reasons, for political reasons, and for budget reasons without specifically knowing the right number of surgeons per capita to maximize health outcomes. Here's some data from David Goodman, who's a Dartmouth health services researcher, looking specifically at surgeon supply trends. What I showed you before was total physician, but if you actually look at surgeons, you'll notice some interesting patterns. Between 79 and 99, so over that 20-year period, just about every surgical specialty actually increased in surgeons per capita, with the one notable exception of general surgery. General surgery was the only surgical specialty that he looked at that actually fell during that period of time in terms of surgeons per capita. Now, this is a slide that's a little complex that I'll describe slowly. What I'm showing here is what I'm going to show here is some data from using the AMA master file, which has information about surgeons and what their specialties are and where they are throughout the country. And then if you look down at the x-axis, I've divided the whole country into 4 different categories: urban areas, large rural areas, small rural areas, and then very isolated areas. So this is that represents the rural-urban spectrum. And what we did is we counted the number of general surgeons per capita in each one of those geographic regions for 2 points in time, 1996 and 2005. What you see is that across the spectrum, there appear to be a slight decrease in the number of surgeons per capita, with the exception of the large rural area, which went up just a tad. So there seemed to be a slight decrease over time in the general surgery population. This correlates with what David Goodman showed in the last slide, that there was a slight decrease in the number of general surgeons over time. But what we did in addition to that is not just look at general surgeons. Let me back up for a moment. The AMA master file, the categorization of what your specialty is not based on what you actually do. It's basically what you say you are. So you say you're a general surgeon. That's what they write down, general surgeon. But there are a lot of other categories in the AMA master file, including abdominal surgeon, trauma surgeon, colorectal surgeon, vascular surgeon, and a lot of these specialties in the real world are combined with general surgery, particularly in rural areas. I mean, if you say that you're a colorectal surgeon and you're working in a very small hospital somewhere, chances are you're doing mostly general surgery. So we wanted to capture that. So what we categorized specialized general surgeons as those kinds of surgeons that I talked about, people who would have had a general surgery background and training, would have been boarded, and then had some kind of specialization, breast surgeon, abdominal surgeon, trauma surgeon, whatever. And if you add those in, what you see is that these numbers actually flatten out, so that in just about every category across the urban rural spectrum, if you add in those people who have called themselves something a little bit special beyond general surgeon, that there hasn't been a decrease, that the surgeons per capita has stayed basically the same. And then the third category of super specialized general surgeons, these are people that have had a general surgery training, but then went into something that was probably not associated with doing general surgery practice, and that would be things like cardiac surgery or plastic surgery. And if you add those in, then you see that in most cases, there's actually been an increase in the number of surgeons per capita. So what this suggests is that across the board, surgeons are simply either saying they're more specialized or are perhaps actually more specialized. And the general surgeons, it's not that there are fewer general surgeons, it's perhaps that they're mostly just calling themselves something else to establish a niche. But the other notable thing about this slide is once you get past the discussion of what's happened over time to the surgical workforce, is that there's a clear disparity between number of surgeons per capita across the rural-urban spectrum. The number of urban surgeons per capita is way higher than it is for small rural areas and particularly isolated areas. Another way to look at variation in surgeon supply is geographically across the United States. Now this particular figure is from the Dartmouth Atlas of Healthcare, is studying the number of specialist physicians. They don't have one just for general surgeons, but for specialist physicians, you can see there's 2- or 3-fold variation in the number of specialists per capita, with the Northeast being a high outlier. For some reason, Colorado, I guess those are the skiing surgeons, and then the West Coast has a band as well. So is there a surgeon shortage? Or is this just a surgeon distribution problem? I mean, that's been the crux of the debate, is whether we actually need to create more surgeons or whether we need to distribute them better somehow, probably with incentive payments to work in areas that need them. But either way, if you're a rural American, it feels the same, whether it's a maldistribution or whether there's a total shortage. You're simply not going to have as many surgeons per capita. So there really does appear to be a shortage of rural surgeons. Now all this is U.S. data. I know there's some Canadians out there, one at my left. And Canada seems to be having the same issue. There's a fair bit of literature about the workforce in Canada. Canada, of course, has huge tracts of rural countryside. And this particular article is asking the same question: is there anybody out there? Not as many surgeons out in rural areas. They're facing the same problem. So let's finish up talking about surgeons and endoscopy. I want to make 2 major points about surgeons and endoscopy. One is that endoscopy is already a very big part of general surgery practice. Those of us who work in tertiary medical centers, we don't necessarily see that, but across the landscape it really is. And then the second point is endoscopy promises to become an even bigger part of general surgery in the future. Now this is data from Dr. Traverso, published a few years ago, where he went and looked at American Board of Surgery statistics for surgeons who are recertifying. So these are established surgeons, been out for 10 years, have been practicing, and they report what's in their practice. And you'll see that remarkably, the proportion of flexible endoscopy is quite significant. That even urban surgeons are on average, doing as many endoscopy cases as they are biliary cases, which, gallbladder is a very common operation. So is endoscopy for an urban surgeon. In rural, it's magnified significantly. Back in the 90s, fully a quarter of the rural surgeons rural surgeon procedures were flexible endoscopy. The other thing that's notable from this slide is that, if you're a rural surgeon, you can sort of puff up your chest and be proud of how much more productive you are than the urban surgeons. Do a lot more cases. Now, flash forward about 10 years to 2005. There's this perception that endoscopy is sort of being taken over by the gastroenterologist, but the data would suggest otherwise. In 2005, 10 years later, that urban proportion didn't really change much, went from 9% to 10%, but look at rural. Rural, 34% of the rural surgeons' procedures were flexible endoscopy on average. Now, you might say, well, that's because all the other good cases are being stolen away to the big hospitals. Well, not so. Look at the total number of cases that they do, 662. You compare that to the last slide, it was in the 400s. So rural surgeons are busier across the board, and they're even more busy doing endoscopy than they were. So, over a third of their procedures being endoscopy. So why does endoscopy promise to be an even bigger part of general surgery in the future? There are a few reasons. One is that endoscopy plays a proportionally greater role in the practice of the kind of surgeons that we need more of, which is rural general surgeons. Market forces are going to be pushing more towards generalism, and it's hard to know what the future holds, but certainly with the changes that we're seeing in healthcare and the way that it's organized, there could be a substantial push in that direction. Second point is that there are vastly underscreened populations, particularly I'm talking about colorectal cancer. But if you look at population-based studies, about 50 to 65% of the population that should be screened for colon cancer hasn't been. And these numbers appear to be increasing over time, and so there's going to be, the number of the amount of screening is increasing over time, and a lot of that screening, as the push continues, will fall to surgeons. And then the third reason that it promises to be an even bigger part of general surgery is notes. I put a big maybe here because I don't think we've yet seen whether notes is going to result in a lot of surgeons requiring endoscopy skills, but certainly with the amount of effort and funding, et cetera, that goes into notes, something's going to come out of it. If nothing else, new procedures and technical skills that will fall into the general surgery practice. So implications and conclusions. I think we should really resist the idea that endoscopy is for gastroenterologists. They may do more procedures per MD because that's the only procedure that they do. But surgeons, if you look nationally, surgeons perform more endoscopy. There are more surgeons doing endoscopy, and more endoscopy is done by surgeons across the country. Second, endoscopy training in general surgery residency is in need of a renaissance, and some of that renaissance is arm twisting on the part of the RRC to get endoscopy numbers yet. But there needs to be a reflected enthusiasm across surgical residencies to take endoscopy training seriously, because for at least one proportion of the surgery workforce, it comprises a third of their procedures. And the profession would do well to revisit the definition of general surgery in view of the need for more rural or truly general surgeons. And this has been discussed at various levels, including the board, trying to figure out whether there should be some way of creating a general surgery track with early specialization for people who aren't doing general surgery. And that would, of course, include a more significant exposure to endoscopy. And the final implication is that you're not wasting your time spending a day in an FES course, because this is certainly relevant for the future. Thank you.